Signs and symptoms of carbon monoxide poisoning are variable and nonspecific, so that unfortunately many cases go undiagnosed. One study estimates that the rate of misdiagnosis is as high as 30%. The most common symptoms in victims of carbon monoxide poisoning are headache, dizziness, fatigue, nausea or vomiting, trouble thinking, diarrhea, weakness, and shortness of breath. Unfortunately, these symptoms can also point to viral illness, a benign headache, or gastroenteritis. In fact, food poisoning was found to be the most common misdiagnosis in one study. Some older reports, primarily from autopsy findings, reported that carbon monoxide poisoning causes cherry red discoloration of the skin. In fact, this almost never occurs. Cherry red skin is rarely noted, even in the most severe cases of carbon monoxide poisoning. But there are some red flags. Some red flags that should raise the provider's attention to do further testing for carbon monoxide poisoning. First, if a patient complains of headache, nausea, vomiting, or other common symptoms that could be due to a viral syndrome or carbon monoxide poisoning, but does not have a fever, carbon monoxide poisoning should be considered. With a focused history, exposure to a carbon monoxide source may become apparent. In addition, if a group of patients presents with similar complaints, particularly if no fever is present, carbon monoxide poisoning should be suspected. Severe carbon monoxide poisoning is less difficult to diagnose. In addition to symptoms, patient developed hard signs of neurologic, cardiovascular, and pulmonary dysfunction. For example, in addition to headache and subjective trouble thinking, patients may show confusion, slowed thought processing, irritability, ataxia, seizures, or loss of consciousness. Cardiovascular involvement may result in hypotension, arrhythmias, and even myocardial ischemia or infarction. Respiratory distress might include pulmonary edema, tachypnea, or respiratory arrest. In general, any organ in the body can be affected by carbon monoxide poisoning. Unfortunately, people who are sleeping or intoxicated from drugs or alcohol can die from carbon monoxide poisoning before ever exhibiting symptoms. The diagnosis of carbon monoxide poisoning is based on a suggestive history and physical findings coupled with confirmatory testing. Patients should be examined for other conditions, including smoke inhalation, trauma, medical illness, or intoxication. Women of childbearing age who are thought to have carbon monoxide poisoning should have a pregnancy test. A neurological examination should include an assessment of cognitive function. For routine clinical use, a mini mental status exam, which takes only 5 to 7 minutes, is adequate. However, there are some special neuropsychological batteries that have been developed to detect the subtle impairment in carbon monoxide poisoning victims that could be missed by routine neurological testing. These tests can be somewhat cumbersome. They require 30 to 45 minutes to perform. They must be administered in a quiet area. The patient must be literate and fluent in English and over age 15. For these reasons, most clinicians simply use a good detailed neurologic examination along with an assessment of cognitive function. Now, appropriate and prompt diagnostic testing is very important. The key to confirming the diagnosis is measuring the patient's carboxyhemoglobin level. It's important to know how much time has elapsed since the patient has left the toxic environment, because that will impact the carboxyhemoglobin level. If the patient has been breathing normal room air for several hours, carboxyhemoglobin testing may be less useful. An elevated carboxyhemoglobin level, which is defined as greater than 2% for non-smokers or greater than 9% for smokers, strongly supports exposure to carbon monoxide poisoning and the diagnosis of carbon monoxide poisoning. An elevated blood carboxyhemoglobin level can advance a case from probable, based on clinical findings, to confirmed. Carbon monoxide levels can be tested either in whole blood or in exhaled air. Blood should be collected in a closed, heparinized container and sent to the lab. If there are several patients from the same environment, often only the most seriously affected need to be tested. Getting lab results can take a significant amount of time, even more so if the lab is outside the hospital. That delay can be detrimental. The most common technology available in hospital laboratories for analyzing the blood is the multiple wavelength spectrophotometer, also known as the COHb. It measures carboxyhemoglobin as a percentage of total hemoglobin. Because a lab co-oximeter can cost $20,000 or more, not all hospital laboratories have them. Most lab co-oximeters can be used to measure arterial blood gases. This leads to the common misconception that carboxyhemoglobin should be measured in arterial blood. This is not necessary and subjects patients to unnecessary risks and the pain associated with arterial puncture. Venous samples are just as good. Venous blood can be placed into a blood gas syringe or any heparin-containing blood sample tube and analyzed on the co-oximeter. The levels in venous and arterial samples are equivalent. If carboxyhemoglobin measurement is unavailable in the treating facility, the patient suspected of having carbon monoxide poisoning may be acutely transferred to a facility where testing is available. It's suggested that a blood sample be drawn first and sent with the patient to the receiving hospital. Recent data reported by Dr. Hampson indicates that human blood stored in vials containing the anticoagulant heparin remains stable. In fact, carboxyhemoglobin levels in whole blood samples with heparin are stable with or without refrigeration for up to 4 weeks, whether the vial is shipped or transported with the patient. While we don't recommend shipping the blood sample because of the time delay, we do recognize that it does happen. The conventional 2-wavelength pulse oximeter is not accurate when carboxyhemoglobin is present. Recently, the Food and Drug Administration approved a 4-wavelength pulse oximeter that solves this problem. In addition to measuring heart rate and oxygen saturation, this new device also measures carboxyhemoglobin levels, all in just a few seconds. We're hoping that this new technology will bring the capability to measure carboxyhemoglobin levels to more hospitals. This would speed diagnosis, reduce the number of misdiagnosed cases, and reduce the need to send out lab samples for analysis. While carboxyhemoglobin levels do confirm the diagnosis of carbon monoxide poisoning, it's very important to note that severity of illness, rather than carboxyhemoglobin levels, should be used to determine the type and intensity of treatment. Carboxyhemoglobin levels do not correlate well with severity of illness, with outcomes, or with response to therapy. It's also important to note that carbon monoxide can be produced endogenously as a byproduct of heme metabolism. It is possible, therefore, for a patient to have an elevated carboxyhemoglobin level as a result of hemolytic anemia or hemolysis due to sickle cell disease. Another approach that is occasionally used to document exposure is measurement of exhaled carbon monoxide with a breath analyzer. Sometimes breath analysis can be difficult since patient cooperation is needed. This may be complicated in the case of young children or patients with altered mental status. Normal exhaled air is 0 to 6 parts per million for non-smokers and up to 70 parts per million of carbon monoxide in the breath of smokers. Measuring environmental air is another consideration. Many fire departments do have the equipment to make these measurements. More than 50 parts per million of carbon monoxide merits further investigation. More than 100 parts per million will likely cause acute symptoms with sufficient exposure time. Now, in a 2005 study in the Journal of the American College of Cardiology, it was found that cardiovascular sequelae of carbon monoxide poisoning were relatively frequent. In that study, 37% of the patients with severe carbon monoxide poisoning experienced a myocardial injury. So in patients with severe carbon monoxide poisoning, it may be important to perform an EKG and measurement of cardiac blood markers. This study also showed that patients with carbon monoxide poisoning who developed cardiac enzyme elevations and/or EKG changes have an increased risk for mortality over the next 10 years, even with aggressive treatment. The exact reason for this is unknown. Unfortunately, right now we do not know which of these patients, if any, need stress testing, echocardiography, or cardiac catheterization. An increase in angina can be seen even with mild elevations of carboxyhemoglobin levels in patients with pre-existing angina. An increase in arrhythmias in patients with coronary artery disease has been noted at carboxyhemoglobin levels as low as 6%. Severe carbon monoxide poisoning can cause myocardial infarction even in patients with normal coronary arteries. Chest radiography is recommended for seriously poisoned patients, especially those who had loss of consciousness or cardiopulmonary signs or symptoms. Brain CT or MRI is also recommended in these cases. These tests may show signs of cerebral infarction secondary to hypoxia or ischemia. To summarize, the diagnosis of carbon monoxide is best made when an elevated carboxyhemoglobin level is documented concurrently with a history, signs, and symptoms suggestive of carbon monoxide poisoning. Now, some other testing, such as a fingerstick blood sugar, head CT, or lumbar puncture, may be needed to exclude other causes of altered mental status when the diagnosis of carbon monoxide poisoning is inconclusive.